Welcome, everyone. It's almost 8 o'clock here in Florida, and I'm Guy Yatros, and I'm here with Lisa Herdt. I'll make some introductions in just a moment. We just want to go ahead and start the broadcast, make sure everybody can get in, and we will start promptly here in about 1 minute. This is kind of exciting because we've done a lot of billing webinars, but this is going to be a little bit more focused on what you need to do if you want to do this yourself, as far as how to get things set up with your billing, MPI numbers, and really what you need to do to get started. So we're excited to do that.
Absolutely.
And Lisa, I see it says 8 o'clock on my my phone here, so I'm going to get started.
All right.
If that's okay with you. Welcome, everyone. We'll have time for questions after this as well. It is if you'll put the questions in the question and answer Q&A down the bottom, that'd be great. You can put them in the chat, but the Q&A is better for us, and we'll get to all of them as we go along. And I'll start by introducing myself. I think, Lisa, the next slides, that you're in control of the slides.
Sure.
I'm Guy Yatros. I'm with Dental Sleep Solutions. A lot of you probably know that. We've been, my partner Richard Drake and I set out on a mission about over a dozen years ago now to help dentists treat sleep apnea with dental devices and to help put all the systems in place, and that's what we do. We've been doing this for over 20 years individually, 40 years between us. We've done thousands of devices, and we just want to help you all do this in your practice. And I've got the pleasure of meeting Lisa Herdt a few years ago when I interviewed her, and I immediately liked her because she's from Kentucky, where I'm originally from, as well, as you can still tell after 30 years of being in Florida from my accent here. And Lisa is our head of 4-pillar billing, has over 20 years, I think pushing 25 years of billing expertise. She does the billing for hundreds of dental offices doing dental sleep. And I'm just going to try to stay out of her way for the most part tonight and maybe ask some questions. If you have questions, again, type them in the Q&A box, and we will either answer them verbally or type them back. And we will stay on as long as necessary to get your questions answered. So, Lisa, thanks for doing this. Welcome.
Thank you very much for having me tonight. So we're going to get started about just how you have to even begin, more about the business of dental sleep medicine, I guess, than the process of the clinical and everything else that goes into it. There's a lot of legwork that goes in on the front end. So we're going to just walk through it one step at a time about what you need to do to prepare to get ready for being able to file claims and being recognized as a DME provider. So you have to start with your NPI numbers. Everybody has an NPI number that's a physician. They usually have a type 1 or an individual NPI number. There are also type 2 NPI numbers that identify you as a group, and then also taxonomy codes. So we're going to discuss each one of those in details, but you have to make sure that this information is correct. Otherwise, you'll run into some hiccups along the line with submitting claims and getting claims paid. So you want to try to make that as smooth on the front end as absolutely possible, because trying to navigate through the maze of things on the back end or while you're in the process can be very time consuming. So what's the purpose of each one of these? A type 1 individual or type 1 NPI number identifies you as a professional. Who are you and what are you doing? So everybody that owns a business has an NPI number for the most part, and it identifies who they are. The type 2 identifies your practice, the building, the name of your organization, and a taxonomy code identifies your specialty. You can have multiple specialties, and we'll look at some of the NPI registry, because I've got Dr. Yatros's. I went ahead and pulled his information up and dropped it into the next slide so we can see what that looks like. But it starts putting all these puzzle pieces together to start building this picture about who you are, what practice you are owning or you're registering with the NPI registry, and then the specialties that you're providing. And you can have multiple specialties. Dr. Yatros himself is a dental sleep medicine practice only, but he could also have general dentistry that identifies him as a specialty too. So you can have multiple specialties. So we're going to review those so you can see what they look like. The NPI registry is a registry that is free to the public. You can look up anybody's NPI number that you want to. So none of this is proprietary or secret or anything like that. It's not like your tax ID number that you want to keep close to the cuff. So you can go on and you can search by name, or if you have the NPI number. So the very first NPI number that I have for Dr. Yatros, in the NPI type, you'll see a little building. that's an identifier that lets you know that that is his group or organizational NPI number, because it's the building, which makes sense. So it lets you know what that is. And then you can see his primary taxonomy code is durable medical equipment. And you have to add these things, but you can do that by clicking on the link that is provided, and we can send that to you if you want. And you can absolutely go on there and make any changes to that as needed. And then the individual NPI number, it has a little silhouette of a torso. So that's how I know that's his individual NPI number. It's really important to make sure that you keep this information updated with your address, because what insurance companies do is they will review the NPI registry, and that's where they'll send checks to. So if you're having checks go to a wrong address, or payments not going where they're supposed to, or missing EOBs, this is probably the culprit that's causing your problem. So if you can get that updated, that's a really good idea to get that taken care of.
So my individual NPI number,
Yes.
is that the same as if I was as a dentist, or is this for medical only, or tell me about
No.
that?
Yeah, absolutely. It identifies you as a person, so you can have, it's not linked to your dental. That's
Okay.
probably when you initially got it, is when you
All right.
first became a dentist, and when you started working, they got you an NPI number. Usually the ADA helps you navigate through that when you graduate from college, and
Okay.
so they will help you navigate through that. But this stays with you for your lifetime. It doesn't go anywhere.
So if someone's right out of school, they need
Mhm.
to go to, is it to this website where they go to apply for this?
Yes, they'll need to go to this website, and they can
Okay.
apply for an NPI number. And
Okay.
if they are an owner of an organization, then you're going to want to get a type 1, which is your individual, and
Right.
a type 2, which is your group. And that also saves that practice name, because once a name is registered, no one else can register that same name on the NPI registry. It won't allow them to do it because it's already a name that's taken. So I would suggest when you get out of, and if you think you're going to have a practice, I'd go ahead and get a type 2 and save your practice name for when you do get a practice. So that'll save you some time on the back end with having to change names so much. Okay.
Okay. And is that same for all three of my offices too? You can
Now
add
each,
extra direct, or you have to register all three of them.
it's
I'm
going to
learning
be,
something here myself. So
yeah, each location has their own type 2 or group NPI number. So you
okay.
have 3. So each of your locations has a type 2, and then you are linked to that type 2 at the insurance companies as
Okay.
well as on the NPI registry. So,
Okay.
and I usually manage those for you, so I try to keep those updated
Yeah.
as well. So,
Yeah. I notice I get emails about every 90 days or so
mhm,
asking if this, and so you got to make sure that it's up to
absolutely.
date. And if it's not there, then no one's going to pay us, right? That's what it
Absolutely. You
amounts to.
won't get any checks in the mail, and they hold them. Once they get the checks back in the mail, and if it's not, if they don't forward, if there's a do not forward, they just hold those. They just hang on to them until you call and get it figured out. So you want to make sure that that's all set up on the front end before you ever do anything with any claims, submitting any claims. You've got to have that front end game pretty tight. So, but
Okay. Can I
yes,
pause for just a second too and ask that
absolutely.
someone type something in the questions or the chat? I think I see one chat.
Hmm.
You all can hear us okay. It's always very strange when you do webinars as opposed to meetings. Want to make sure we're not, one time Rich and I forgot to start the meeting and realized no one was hearing us. So somebody that knows us out there, just type something in the chat that we're coming in loud and clear, or put it in the question box as well. If you have questions, put them in the question box and we're going to get to them. So I think,
Absolutely.
all right, great.
Yeah, there they
Thank
go.
you for responding to us. It's much, if anybody's ever done these, it's much easier to speak in public than it is to a computer with it. You don't know if there's some IT problem or something going on. So thanks a lot. Go ahead, Lisa. Well, this is
Absolutely.
interesting to me because I know I do get these emails and you all handle this, and you
Mhm.
prepared this PowerPoint, and I looked at it and I said, well, I don't know what a lot of this stuff is, so I'm going to learn something tonight myself. So I'll be
Absolutely.
quiet again for a minute. Go ahead.
Sure. So when you're needing to make updates to your NPI number, like if you move, because it goes with you wherever you go. So if you move to a different location, you're going to want to update that address. Keep those records updated as much as possible. If you don't have a type 2, we recommend everybody obtain a type 2 NPI number. The reason being is, one, Medicare requires it for credentialing. The insurance companies have recently started requesting a type 2 NPI number because they're starting to put the dentist into the same category as the DME storefronts, the brick and mortar stores. So as you know, when you go in and get crutches, they submit that under the NPI number for the organization, which is the building. So they're starting to do dentists that way as well. So we usually get that type 2 number in NPI number updated with the credentialing through all of the insurance companies, and that way you're good to go. And we'll link the individual to that. So there's a whole process that goes into that we'll get into in the next couple of slides as well. So
and I assume that's why I know typically if you use a billing company, a lot of times there's a setup fee when they come on board. This is so that you go in and you put all that information, you link up so that the billers basically recognize you. Is that
absolutely. Yeah, I have some slides in there. We're going to talk about how that credentialing process works and some of the legwork that goes into that and the time frame as well. So, but yeah, we'll get to that in just a moment. But make sure you have that taxonomy code added as well to one of your specialties. Again, you can have multiple specialties on your NPI. You need to do it for your type 1 and your type 2. Just in case that insurance company requires that type 1, when they process a claim, what they do is they look at that taxonomy code, and if it's outside of the scope of that taxonomy code, or if it's not your specialty, they will deny claims as well. So they're always looking for reasons to deny, always.
Okay, so if someone's going to bill Part B, like or something for exams and so forth, then they would need to add that taxonomy code as well. If you're going to bill exams, and you would need to have something in addition to durable medical equipment.
Absolutely. So if you need any help with getting set up, we do that for all of the members that come on board with 4-pillar billing. It's just part of our process. If you're interested in doing some self-billing by yourself, consult with someone. It doesn't necessarily have to be me, but consult with someone that's very familiar with the way this works, because to try to unravel it later on can just become a can of worms. So it's easier to do it on the front end than try to fix it later on. So you want to talk about the housekeeping?
Yeah. Again, I see some questions coming in. We'll get to those. I think it's a good question to answer live, the one that just came in. So we'll get that in a little bit. Yeah, you do get CE for this. It'll be in your email within 48 hours or so. If it's not, check your spam. And then if you don't see it, then by all means, let us know. But it should go to the email that you registered with. So that's it for now. We'll talk about some other housekeeping in a little bit.
Sure. So the next steps, once you get the NPI registry and your type 2 and your taxonomy code added, and it's all squared away and it looks pristine because it needs to look just so, once that is done, then the insurance companies have started networking with it's a non-for-profit organization. It's called the Council for Affordable Quality Healthcare. It's a repository that is free to dentists or medical providers, any medical provider, that they can put their information into, that will house all of their demographic information, their education, their training, their DEA license, certificate of liability, any license that they may have, and insurance coverage, and you can deposit it into the CAQH, and they generate a number. So you get a CAQH number. Most of the insurance companies require that you complete this. So you have to get it done, and specifically Blue Cross Blue Shield. Humana has recently started doing that, and we've seen Aetna require that as well when you do the credentialing to get the doctor recognized. Council for Affordable Quality Healthcare, they have the insurance companies pay them for the service. It's free for the medical society and for the medical providers, but the insurance companies have to provide they pay a fee to get access to have all of your information in one place, and it saves them employees. So they don't have to have anybody to verify all of your demographic information, all of your insurance. It's all in one place. The other thing that's really good about CAQH is it's a good practice management tool. So if you enter your certificate of liability, for example, and it's ready to expire, the CAQH will send you an automatic email. And Dr. Yatros, I know you get these
got
too.
One recently,
yeah. You'll send me an email and say, are we taking care of this, or do I need to do anything? So, but they will send you an email saying your certificate of liability is getting ready to expire. You need to upload a new one. They will prompt you to do that. They will also prompt you about every 90 to 120 days to go back in and verify all of your information. That's way when the insurance companies go and review that criteria, they have it all in one spot, and they have to pay for it. So that's the only good thing I can find right now that insurance companies have to do versus, the dentist or the provider's always taking a hit. So
it's free for us. They have to pay to access, but it makes their lives better. And that's why they do it. And I think an important note here is I do get those emails, and I do forward them to Lisa. If you're going to set this up on your own and you're the dentist and you're having John or Jane do this in your office, make sure that that email comes to you, the dentist, in case John or Jane decides to leave your office.
Right. Absolutely.
Because the email's it's important that you get this and make sure that that someone who's going to be there for the long haul gets that email. So that's why we have it set up for me, because I always know to have it is important, because if that's not updated, then we may not get paid.
Absolutely. And what I always do as well, just to ensure that we have all the information. So that was a very good point. I always create a provider binder. I've got one for Dr. Yatros and for Dr. Ellica for both. It has all their user IDs and passwords, and I keep it in my desk. And that way, if something were to ever happen, it's all right there at their fingertips too. So they have the access to it as well. So, so the next step is, you need to provide the demographic information. They need to know who you are, where you're at, and what services you're providing. I suggest using the type 2 only. We ran into a challenge about a year ago with insurance companies, specifically United Healthcare. When we would send the type 1 or individual NPI number, they would link it to the dental, either agreement or contracts, and they would mix up the payments, and it became a mess, or they would undo the in-network contract you had on dental. So we stopped doing the type 1. It just caused too many problems. So we stopped doing that. We do the type 2 only. If you only have a type 1, it can be done. It may take a little bit longer, but it can be done. We typically follow up with the credentialing department about every 10 business days. They tell you it's going to take 30 to 45 business days in order to get your credentialing completed. It doesn't usually take that long, but that's their standard across the board for claims and pre-auths and everything else, is that 30 to 45 day mark. So you need to start doing that if you're going through training. These are things that need to run simultaneously together to make sure that when you are up and running, your training's completed, if you're going through any type of training, and then also your credentialing so you can hit the ground running. You don't have to wait to treat patients, and Dr. Yatros will probably touch on that a little bit for me. Don't wait until you get credentialed. Do some fee-for-service options, treat somebody in your office. Don't wait for this to be done. So is that something that you would recommend, Dr. Yatros?
Yeah, I think the biggest mistake dentists will make is thinking everything's got to be perfectly in line. The star is going to be just right to get started on this. You'll learn a lot by getting started. So, you don't build this until you deliver the device anyway.
Right.
So let's don't hold up on getting started. And we
Absolutely.
often recommend doing a fee for service when you're first starting, while you're getting all this arranged, while you're learning how to do this. Again, I see we have some questions coming in, some about out of network billing. I think we'll get to that when we have some information about that in a little while, and we'll get to those. So keep them coming. We will answer these along the way. So I think there is one here that I think maybe is appropriate for now. As long as you don't have a dental contract using a type 1 NPI, shouldn't interfere with the DSM agreement, would it?
It shouldn't. Now, you'll have to keep in mind that when you're using your type 1, it could intermingle payments. So if you've received one bulk check from Humana, whether you have an in-network contract or you're just billing a medical service for dental there, it can intermingle the money. As long as if you don't have any contracts with any of those, it shouldn't cause a problem at all. But we ran into an issue with some providers that did have contracts and it caused a problem. So that's why we switched to using the type 2 only. Okay. Right. And this is the sample demographic form that we use. I gathered all of the information. We created one form for all insurance companies. Not every insurance company requires all of this information, but we thought, just might as well give them everything in case they decide to change their mind at some point in time. So we created this form, and this is what we send to the insurance companies to get a medical profile set up for the dentist. So this gets you credentialed as an out-of-network provider. We always have that note that says, please do not terminate my provider's dental profile, because sometimes they will do that. United Healthcare was really bad about it, like I said. So we made sure we put it in big, bold print. And sometimes we have to talk to some supervisors and some team leads and things like that, because they will still try to route it to dental. So we still have to stay on top of them. That's why we call about every 10 days to find out what's going on with that process, to make sure they didn't route it to a wrong department. That happens often.
So when you're doing billing for another company, this is the information you're going to gather to have at your fingertips to get this ball rolling on all that
Yes,
stuff.
absolutely. So what we obtain from the providers when they come on board is we gather all their CAQH, their W-9, all of that information, and we create a provider file for them, like similar to what I did for you. So I create that provider file, and then we save all of that information. And when the insurance company needs a piece of information, we have it at the tip of our fingers. So, yeah. So you want to talk a little bit about this for me?
Yeah, sure. I mean, what we do here at Dental Sleep Solutions is we help you with what we call the 4 pillars: screening, testing, treating, and billing. Today we're talking about the billing, but if you need help with anything, dental sleep wise, along the way tonight, type in consult and someone of our team will schedule a time to meet with you and just help you with those challenges. And it's, it's really worth your time because we have a whole room full of people. That's all they do is help dentists across the country do this. So
Yeah.
that's what we're all about here today. We're talking about the billing. One of our departments, we do billing for you if you want, but we know some people want to do it themselves, and so that's why we're having this one, this meeting today. And if you're after reviewing this, you decide you want some help, Lisa's the head of our division, what's called 4 pillar billing, who can help you there as well.
Absolutely. So we've done some research recently and done some investigation around some barriers, and billing comes up quite a bit in that barrier column, as I see. So we like to make sure that we provide a way to overcome those barriers. And if you're set on doing the billing yourself, we want to make sure that you're successful in getting claims paid and getting patients treated. So that's the ultimate goal. So another barrier that comes up sometimes is people talk about Medicare. A lot of people are terrified of Medicare. For me, in my opinion, Medicare is probably one of the easiest insurances to bill because you know exactly what you can do and what you can't do. So who are the Medicare beneficiaries? Who are they? Medicare is a federally funded program. You can be 65 plus and or disabled. You don't just have to be 65. People with end-stage renal disease, they're eligible regardless of age. But the most important part is Medicare is not a form of welfare. It's not a Medicaid. And I think a lot of people get that confused. And I think there's a lot of people in that category that are 65 and over. There's probably, I think I did some research and there were over, they estimated 200 million people or something like that to be in this category very soon. So we need to make sure that we're being able to provide those. So don't be afraid of Medicare. It's one of the easier ones to do.
And we have a question coming up that's what do we need for Medicare? And we have a question currently. We'll be getting to that in just a few minutes. So I'll just let that person whoever typed that in to hang in there.
Okay, perfect. So with Medicare, you'll have to do a couple of things. You need to make a decision about what you're going to do because a decision has to be made. So you have to pick one. If you don't want to treat Medicare at all, then you're going to need to fill out a form. It's an affidavit with your region or your jurisdiction for Medicare saying, I'm not going to be a Medicare provider. I'm not going to treat Medicare patients. You can't file any claims to them, and we'll get into some more details as well, but you have to make a decision. There are 2 other options. You can be a participating, and that means that you'll accept their payment in full. And we'll go into more details as well, or non-participating. I personally recommend non-participating, and as we go through some of these differences in the options that you need to make a selection on, I'll tell you a little bit about why I lean more towards non-participating, and we'll be able to help you make some decisions there as well. So like I said, if you opt out, you have to sign that affidavit. It does last for 2 years, which means you cannot file claims for 2 years. But due to COVID-19, this restriction has just been lifted. So if you are a provider that opted out, if you want to now start treating Medicare, they're waiving that. So you can opt back in at any point in time. There's a form that you have to fill out, but you can send that into Medicare and you can go ahead and get started again with Medicare at that point in time. So that's a good thing that's come out of the COVID-19. If you opt out, go ahead.
And make sure that we understand we're talking about DME here.
Yes.
I know when I give lectures, sometimes people think, well, I filled out something for ordering and prescribing. That's a different division of Medicare entirely, correct?
Absolutely. Yes. DME is an umbrella under Medicare Part B, and it's a completely separate application from the physician services. So they are 2 totally separate applications. If you opt out, you cannot bill Medicare. Patients can't submit the claims either for any Medicare services, and you must have an advance beneficiary notice signed if you're going to treat them as a cash paying patient. They have to be notified in advance that you are not a Medicare approved provider and they are responsible for the payment. And we can get you a copy of the advance beneficiary notice or the ABN, or if you're a DS3 member, they're already embedded in the software. They're available for you to do that. Or you can do a Google search and find it on Medicare's website as well. Okay. So we're going to talk a little bit about the Medicare application process, but I want to go back to the participating and non-participating for just a moment before we get started with this. My thought process about being a non-participating provider is you have flexibility to be able to balance bill patients up to a certain dollar amount, technically up to your full billable fee. I'm not recommending that you necessarily do that, but it gives you some flexibility. You can also accept assignment of benefits on a case-by-case basis if you're a non-participating provider. So if you have a patient that you know that's been a patient of record for yours for a really long time, and you know they're living month to month, at that time you can opt to go ahead and accept assignment on that one claim only, and you can accept that as payment in full. So just make sure that you understand the differences between participating and non-participating, because it can be it can mean a huge difference in some instances as well. So just make sure if you have any questions about that, let us know. Make sure I'll reach out to you and we can talk a little bit more about Medicare as well.
Yeah, and I can see really no reason to be participating for what we do,
Right.
because you can flip back and forth, like you said. So it just, I've not heard a good argument why we'd want to do that just yet for most general dentists doing dental sleep.
Absolutely.
There might be a good argument for other specialties, but.
Absolutely. So the Medicare application process, the link is here. You'll be able to see it, but you can Google search 855S. It's a very specific form. That is the form for durable medical equipment that must be completed. It's typically a very lengthy process. On Medicare's website, or if you were to call them, they would typically tell you that it'll take 6 months to a year to be approved. Time consuming. The Medicare application is about 30 pages long, and for durable medical equipment, it has to be very specific about what's completed. So you really have to navigate through that application pretty clearly, otherwise you can run into some issues and hiccups as long. But right now, due to COVID, they're trying to get as many people pushed through the pipeline to be Medicare providers. We're seeing them turn around right now because they've lifted that restriction, and we'll go into some of those as well. Now we're seeing it probably be about 6 to 12 weeks to get approved to be a DME provider. So now's the time. If you're going to do it, now's the time to do it. The application fee, because Medicare charges you a fee to process that application, it's $598. Right now, due to COVID, they're waiving that. So if you've thought about it, now is the time, because we don't know when they're going to take that restriction, put it back in place. So we're hoping that it'll last.
Are they waiving it or are they postponing it? They're waiving it?
No, they're waiving it.
Can I get my money back or no?
I can ask, I can ask. I could give them a shot and ask.
Okay.
But yeah, definitely. Wow. Yeah, they're waiving that. They're not talking about going back and doing that. Okay. Talk with a third-party vendor. A lot of the billing services provide this as a service to get it completed for you. You can check with them. They usually charge a fee somewhere between $1,000 and $1,500 to complete that, because there's a process that goes into that. They have to monitor it. They have to keep in contact with Medicare. Medicare may send what they call development notifications if they need additional information from you, and you have to respond within a certain time frame. So you want somebody that can be on top of that and monitor that.
Yeah, I just give you a quick advice. If you're the kind of person that does your own taxes, then go do this yourself.
Right.
If you pay someone to do this, then you might want to do your taxes, and you might want to pay someone to do this, because it's not hard, except for you got to know where all the stuff goes, and a lot of times it gets kicked back. If you want to contact us, we can put you in touch with people that'll do that for you and get it done a lot quicker, and you can go back to doing what you know how to do.
Yeah, well. Absolutely. So for the Medicare application, what the requirements are. So this is what we're going to talk about for the requirements. You have to have the completed application, of course. And right now they require DME providers to have a $50,000 surety bond per location. So if you have 2 offices, you have to have two bonds that cover you up to $50,000, or 1 bond of $100,000. So that's a requirement. Typically before, they would require fingerprints because they did fingerprints and a background check. Right now, due to COVID, that's being waived.
Wow.
I'm not looking at going back and doing that. So that's why I've got newsflash. These things are, as this unravels a little bit and we figure out what our new business as unusual is going to be, is this is one of the things. So we try to keep our finger on the pulse of what's going on. So that's been going on for a few months. So take advantage of that. This is what used to cause the biggest delays, is when you'd have to go somewhere and get your fingerprints done, and then they'd send it off, and then it would take
Right.
4 or 5 weeks to get it back from there. And that's what caused most of the delays. So also they do a site visit. They want to come by. Sometimes they come into the office. They want to make sure you're a legitimate business. They look for certain things like the hours have to be posted on the door. The name has to be posted. There's a lot of criteria that they require. And if somebody wants to know what's required for a site visit, we have access to that as well. If you're a DS3 member, you can look that up in our Snoozle, our search engine, and you can find that information there. But right now they're waiving that as well. They're not doing it. That's why this is expedited now. So it's sped that process up.
And that site visit really isn't a big deal,
No.
but it's kind of a hassle. You've got to be there, and biggest
Mhm.
thing people will get pinged for is not having their office hours on the
Right.
doors. But right now, that's being waived. And are they going to do it later? They're just not doing it at all, or you don't
They're
know?
not doing it at all. When I
Okay.
talked with my
Huh.
contact at Medicare, she said, we're not looking at going back and redoing any of this because we've got
Yeah,
too
they're gonna be
many
too
other,
far behind.
yeah,
Yeah.
they couldn't be able to do it. So it's a really good time to strike while the iron's hot. So
Absolutely. There's never been a better time. A couple of questions. There's other ones in here. We're going to get to all of them. So if you typed a question and we haven't addressed it, we will get to it when at the end. It maybe just doesn't fit in right now, but I think this one does. Is the fee the same for revalidation? I
it
assume
is. It
it is
is
the
same
same. And
for,
are they not
yes.
waiving that currently, or are they?
They are waiving the
Oh,
revalidation
okay.
fees right now. Yes.
Okay.
But make sure that if you're going through revalidation, they're waiving that fee. I've also heard, and I haven't confirmed, so I've just heard that they're not doing any deactivations right now. They're holding off on doing deactivations. So you may be able to buy yourself a little bit of time. I wouldn't push it too far because Medicare can be unforgiving.
Yeah. Right.
They'll just change stuff in the middle of a process. So just make sure that you're staying on top of it. But if you get anything that says CMS or anything like that in the mail, make sure it's a priority in the mail slots somewhere.
Right. One
Yeah.
other question I think related to Medicare: is it
Mhm.
easy to change your DME address if you're planning to move your office related to
It,
Medicare
It
requirements?
is. There's only one section that you would have to fill out for that form again. It would be your address, and you can do an update. You still have to have a new signature page. So what we'll do in most instances is we will pull the original application, and we will put update and just slide in a new address and then a new signature page. And you can send that in. Now it does take about 30 days for that to take in effect. So you're going to want to make sure that you give yourself enough leeway to make sure that that's updated before you start treating Medicare patients at that new location.
We've got some other questions about Medicare. One from a good friend, John, there. We'll get to that at the end to not let Lisa run over here. But we'll get to all your questions. Keep them coming. And Lisa, I'll let you go on because I don't want to have you running behind. We can just talk. We've already kind of talked about what we do.
Mm-hmm.
If you'll need help with that, let us know, and I'll let Lisa just move on so that we can
Sure.
keep you on track.
Absolutely. So now we're going to talk about group health insurance, not Medicare, just group health insurance that most of us have through our employers. Becoming in network, it can be a very lengthy process, even if they will allow a dentist to be in network for DME. We've run into some challenges along the way with certain insurance companies, specifically Blue Cross and Blue Shield. United Healthcare is difficult in some states, but not all. So we've had some luck with United Healthcare in a few states, not very many though. It's very regional specific, whether they'll let you in or not. You must abide by that contractual agreement. So you have to do write-offs. You can't balance bill a patient. You're locked into that specific dollar amount. But the billing systems are easier. You know how much you're going to get paid because you know the patient's deductible and their co-insurance. So you already have this information, or you should have that. And if you have an in-network agreement, you know how to calculate how much that patient's going to owe. And typically the deductibles are less, is what we see with in-network benefits and agreement. Out of network, in my opinion, you have more flexibility. So it's just a whole lot more flexible. Uh, Typically what we see is a higher reimbursement if you're out of network than if you're in network. Most of your in-network contracts usually start out at the negotiation at about 110% or 115% of Medicare in your area. But we're seeing an average reimburse or average allowable amount over the last probably year and a half go up a little bit, but it's hovering right around that $2,000 to $2,100 mark is what we're seeing is an allowable amount. You do have to be more diligent about your processes. You know, the billing can be perceived as being more difficult, but if you have a really good person in place to make sure that they can have those financial conversations, it can be very successful as well. And you can always apply for a gap or an in-network waiver, but those are getting even more difficult to obtain as well. So we run into some challenges with that. Again, it's not impossible. You just have to make sure that you have good systems in place to make sure it happens.
One thing I'd like to make clear on this too is that
Mhm.
for Medicare, you have to make a decision. If you're
Yes.
going to treat Medicare patients, you either need to opt out, become a participating, or be a non-participating provider. Technically, you're not supposed to see patients until you've done one of those, the above.
Right.
For commercial insurance, tell me if I'm wrong, Lisa, but if you don't do anything, most likely you're going to be out of network by default, unless you had some contract with them through dental that carried over somehow,
Correct. Yeah,
right?
correct. That's absolutely correct. So when we're
And you
talking,
can
go ahead.
you can be commercial insurance. You can be in with some and not with others too. I think that's something we can talk about. There's some questions about balance billing we're going to get to maybe towards the end here.
Sure,
I
of
think when you're
course.
talking about that, it's unclear on the question whether it's Medicare or commercial. I think we'll
Okay,
take a moment and talk about that towards the end,
perfect.
so we can stay on afterwards to keep you on
Okay,
track here.
absolutely perfect. So when a patient comes into your office, you need to know what type of insurance they have. Usually the ID cards are pretty clear. It'll usually have the HMO or PPO listed on the insurance card, but you need to know what that means to you as an out-of-network provider. An HMO is a health maintenance organization, and it's very reasonably priced. So a lot of people will opt to that so they have less premiums coming out of their paycheck. So it's the most affordable, but it's the most restrictive. So it's very strict. You have to have a primary care physician, specialist referral, and you only have in-network benefits. And if you vary or deviate from that at all and you go to an out-of-network provider, there's no coverage. So, I mean, it's very restrictive. Your PPO policy is on the other end of that. It costs more, but it's less restrictive for the patients. So the way you treat these in your office can be different. So you need to understand what each one of those are and how you attack them. If an HMO patient comes into your office, you need to be in the mindset that you're probably going to have to go down that path of fee for service for them because there are no out-of-network benefits. So it can
Unless you
vary.
can get gap coverage, which is harder and
Yes,
harder to get these days. So
absolutely.
if the gap coverage is no one's in your area that is in network, then you might be able to get that covered.
Absolutely.
Right.
Yeah. And a lot of the HMOs now are asking that the primary care physician or the patient initiate that gap, which both of
Right.
those people have no idea what to say or what they're even
Right.
talking about.
Right.
So that's another challenge that we run into as well. Again, it's not that it can't be done. It's just getting more and more difficult. So
Right.
I just wanted to discuss a few different plans. That way you have an idea about what that is. One of the most important things, in my opinion, that you need to do is verify the patient's benefits. What I mean by that is you need to have a way to verify their status. Are they active? Do they have active medical coverage right now with people being laid off and things like that? They may be changing jobs or they may lose their insurance. So you're going to want to make sure that you know if they're active or not. And then you're also going to know their in and out of network deductible and their in and out of network co-insurance, that percentage that they're going to be required to pay as well on top of their deductible to make sure that you're able to have a financial conversation with them. And this is one of the most, in my opinion, one of the most important things, because if they're not active on the date that you deliver the device, that's your date of service. If they're not active on that date, even though you've done all this work beforehand, all of that, it doesn't matter. It's for naught because they're not active. So make sure that you have something in place to be able to identify what their plan status is and if they're active. Do anything except get on the phone because that you're going to be on the phone all day long, all day long with an insurance company trying to figure out if somebody's active or not. And during COVID right now, some of them aren't even taking phone calls. So there's another challenge.
Well,
So
we know
like,
through DS3 we can hit a button and most of the time
absolutely.
figure that out
Yes.
with in almost most every case.
Absolutely. So make sure you have something in place. You need to be able to verify that. Like he said, with DS3, you have the instant eligibility check, or your billing coordinator or billing coordinator can absolutely figure that out through maybe another resource for you as well. So 90%, if not more than that, of the commercial insurance or group health insurance plans require a pre-authorization. So a pre-authorization is different than a predetermination that most people are used to in the dental world. So you have to make sure that you have certain things in place before you request a pre-authorization for dental sleep medicine. You're going to need to have progress notes. It's very important that you have progress notes, and they have to be signed. We suggest that you have a CPAP affidavit showing that the patient they're within a certain range, whether they're mild or moderate, and they're opting to use the dental device as their first line of therapy. Or if they're severe, you're going to want to have them document why they can't use the CPAP. So you need to have a CPAP affidavit explaining that to the insurance company as well. Any comorbidities that you can document. We have patients that'll come in quite often, and on their health history, they'll be taking medicine for high blood pressure. And if you ask them, do you have high blood pressure? They'll say no. Well, no, they don't, because they're taking medicine that regulates it, but they still have it. So you need to make sure that those comorbidities are captured, even if a patient doesn't see that. So just asking those right questions, and you need a sleep test with that diagnosis of OSA before you can even initiate the prior authorization.
And those
So make sure
progress notes, are those from me or from the doctor or both?
they should be from you first, and then they may request additional documentation from a primary care physician. It doesn't happen often, but they can request that as well to see if they've been treated for it in the past. So make sure those progress notes are signed. If you're using a software like DS3, I'm preaching all the time, make sure those progress notes are signed, because they're not valid if they're not signed, according to insurance companies. So now, after you've done all of this legwork, now you can finally file a claim. And it seems like a lot. There's a lot of things that can run simultaneously, but it seems like a lot of work on the front end just to get to file a claim. And I like to say just, because my team files hundreds of claims throughout the month, and it's not just a claim, but there's a lot of legwork that goes into the front end of it. So when you're ready to file that claim, you're going to need a letter of medical necessity. Our software DS3 requires that before it will allow you to move forward. It's a security measure that's built into the software. It's hard coded there. You can't really bypass that piece of it. So it's required. What you'll need as well is a proof of delivery, which means the patient has to sign something saying they received the durable medical equipment, a lab slip, a sleep test with diagnosis, which you have to have for the pre-auth anyway. But for Medicare, you don't have to have a pre-auth, an advanced beneficiary notice if it's for Medicare only, and detailed clinical notes. You have to have these things saved in images or a file or somewhere. You need to have them, because most of the insurance companies will ask for this information. That's another delay tactic that they have. Once you file that claim, follow up about every 14 to 21 days, because they're going to tell you they need medical records. I'm telling you, that's the game they play. So you have to know how to play the game with them. As long as you know the rules, you can be good at playing the game. But if you don't know the game, you know the rules. So that's what they're counting on, is you not knowing the rules.
Right. And don't you click a little box somewhere that says I have all this information, or did I
You
make that up?
do.
Okay. Right.
No, you do.
Okay.
You verify all that. There's certain things on the claim when you submit the claim.
Right.
There are modifiers that say that they're KX and NU is what the modifiers are. But KX means that all of the medical necessity has been met and that you have the supporting documentation.
So you don't necessarily have to send it with the claim, but you're saying I have it if you need it.
Yes,
Okay.
absolutely. Yes, we
I
don't
thought.
send it with the claim. So we have a basic getting started checklist, things that you just need to start looking for when you're initially getting started with dental sleep medicine. We encourage everybody to identify the person in your office that's going to be your sleep ambassador, your sleep captain, who's going to manage this for you, because it can be time consuming. And if you're in a busy practice, and I'm sure all of the clinical staff is probably sitting there nodding their head. If the dentist comes in and hands you one more thing to do, you're going to be like, oh, when am I going to get this done between all the clinical stuff and everything else that I already have on my plate? Have a dedicated person, part-time at first if that's what you need, but make sure you have somebody dedicated to this so you can be successful. Make a decision. Are you going to do self-billing? Or are you going to find a third-party billing company that can provide this service for you? I recommend that if you have not been doing medical billing in your practice and don't already have it in-house for probably a good year or more, that for at least 6 months to a year, you probably need to use a third-party billing company. The reason being, it's not self-serving. It comes from a place of let you get your feet under you with all of the other systems, make sure your sleep ambassador is comfortable, make sure your staff knows how all those things are in place, get those systems together, and then you can take it over. You
Yeah,
know,
and just to emphasize not self-serving, I know at Four Pillar Billing, we have people start out using the company,
you're
but
right.
then if they get busy enough and they say they want to do this themselves, you'll even help train them.
Yes.
You have programs where they can do it via Zoom now. We were doing them in person,
Right.
but so we want you all to do your own billing
Mhm.
at some point, but you wouldn't start your own lab if you're doing 1 or 2 crowns in the back of your office a month. And until you get busy doing this, it doesn't make sense. I think is what you're saying.
Yeah, absolutely. And we run into this because this can be one of the biggest hurdles. That's where we find that it comes up, it bubbles up to the top that
Right.
that seems to be an issue, and we want to try to eliminate that issue so you can be successful. And we're just trying to give you a leg up on the process of making sure that you can get started and get started well. And then you're going to have to make some decisions about being in and out of network. Decide what your fees are going to be with billing to medical insurance. You have to have one set consistent fee for all insurance companies. You can't be changing your fee every couple of weeks, or you can't change it based on Blue Cross Blue Shield allowing more if you bill this amount, or Medicare you bill a different rate. You have to have a consistent fee. So you need to do some legwork about discovering what your profit margin is, what your overhead, and look at what that process is to determine what those fees are. And then look at your cash fee model. What can you do this for if a patient doesn't have any insurance, or if they have a really high deductible to keep them from walking out the door? What could you possibly do, and what's that fee? So there's some decisions that need to be made. And then you can't forget about Medicare. You have to do something with that. Make that decision. If you have any questions about what to do with Medicare, we'll be glad to answer those as well. And then check in to see what type of sleep testing. Are you going to do it yourself? Are you going to have your own units and farm it out to somebody to interpret it? Are you going to network with a home sleep test company? So there's a lot of decisions that go into the front end of this process.
Yeah, this is a great list, Lisa. By the way, there's some questions coming in. We will get to those again. I promise you before we'll stay on late as necessary to take care of those. I would type the answers, but I don't know all the answers. So I'll let Lisa answer in a little bit. But this list, I mean, if you really go back and do this, if you want to do this yourself, then you've got to sit down and make sure you have each one of these figured out as a well-oiled machine. So when a patient comes to your office, we know what they're going to do. And a lot of these have decision trees that go underneath them. So someone comes in, maybe you're in network with one insurance and not the other. You know, they go this direction. Maybe they have high deductibles. So we do that. I know one of the questions that came in, how do we know what they pay if we're out of network? I'll get to that in just a little bit, but we have that's part of the processes that you need to map out. So when you look at these little 6 check boxes, understand each one of these requires further decisions underneath these. This is the high level, and I think it's a great list. If you can get this stuff in order to where all those are taken care of by team members and you know what happens in each of those directions, you'll have a very high success of getting patients to say yes to treatment.
Absolutely.
And getting
So,
paid on the
yeah,
retrospect after you send the bill in, which is
yeah.
even more important.
That's the
Maybe.
goal right there,
Yeah,
is getting
right,
paid. That's
right.
the goal right there. So you want to tell
So
us about your GPS
yes,
courses
so
coming up?
yeah, we've got about 10 minutes left here, and we're going to get to your questions in just a second. These have been overwhelmingly successful. I mean, we're not trying to toot our own horns here, but I can't tell you how thrilled we are that one good thing that's come out of this COVID is we're doing the same courses we used to go around the country, and people had to fly, spend money, and now we're doing these in Zoom format. We just did one last week. We had 25 people on it. We're limiting them to 30 because we want to make them like a meeting. This is Zoom webinar we're doing tonight. These are done in Zoom meeting. We want you to use your camera. We want you to unmute yourself. You can unmute yourself. You can talk just like we're at a real meeting. They're very interactive. We're doing them 3 nights, 7 to 9. Typically, we have altered that some, but the next one's September 1st through 3rd. That's a Tuesday, Wednesday, Thursday night. And really, you're getting the same content as if you came to the in-person course. And I tell you, the people are leaving going, this was the best utilization of time that we've had. You can get up to, 10 hours of CE, because I'll get to how you do that in a minute. You get a free included, a DSM starter kit. You get a MyTap that's worth $100. You get a sample EMA appliance. You get some brochures, this is a little audio visual or visual aid that I use. So what you need to get going, that's about a $400 value. The fee is normally $500. Back it up. What do they get? What is special? I know this just through this week is $300. So if you're interested in that, you can click on it here. They'll drop a link probably in the chat box, or just type course and someone can reach out to you this week to make sure you get that discount. And these are recorded, and you can come back and watch them for a period of time. I think it's about 2 months, 60 days. You can come back and watch them, and you and your team can watch them too, so if they can't attend. And then in addition to that, Lisa does a 3 to 4 hours, depending on how many questions they have, billing session that you can either watch one that's pre-recorded and get CE for that, or you can attend one live in association with this. We do those about every 4 to 6 weeks. The next one of those is September 18th. Is that right, Lisa?
That's correct. September 18th from 11 to 3.
11 to 3 included in the course here, or you can take that one just by itself if you want, but it's about half as much as the whole course. So if you're interested, type in to the chat or into the question box. Probably chat's better. Course, and Mike or someone will get in touch with you. So I know we got quite a few questions to get to here. Before we get to those, I want to make sure, because people may log off here that don't want to listen to the questions. These are some great questions, so I encourage you to stick around. The next meeting we're doing is walking in your dental sleep. We're really going to look at what it is to get going in dental sleep in 2020. A lot of cool things going on with telemedicine visits and things like that. So it'll be September 8th at the same time, and you get an hour CE for that. So register for that. If you're not a subscriber of DSM magazine, Dental Sleep Medicine magazine, there's where you go to subscribe to it. Our next edition will be coming out shortly. A lot of great information there on the current one and the past. And last, before we get to all these questions, because there's at least 7 or 8 of them here that we'll get to. If you just want to have more help with doing this, just type in consultation, and someone from our team, Mike or Brandy or one of our team members, that's all they do is help dentists all day long. If it's a question about billing, one of Lisa's team will meet with you and answer these questions. We don't fully get to it tonight. If it's a question about how do I use telemedicine to get a sleep test, or how do I make a device on an edentulous patient, then any questions about that, type in consultation. Or if you just want to know what we do, how we can help you, we're not pushy people, just type in consultation there. So of course, if you want the discount for this week, because it goes up to $500 after this week, because we have been getting over half of them been sold out. So it's been working really well. So let's get to the questions. If more people have questions on that, we'll get to those. I'll maybe, let's go down through these. I'll read them so that everybody can hear them. And I think these 2 first ones came up earlier on, and I think they're related, so I'll read both of them. Okay. And then let's talk about that. This is kind of a little bit of I think we'll give you an opinion, maybe not the exact answer to this one, but the questions are, should a provider bill as a non-participating provider? If they do, can they balance bill? And then the next question was, I think, sent by the same person, does each state allow balance billing? I think they're talking about out of network there, or do you think they're talking about Medicare?
Well, why don't we just answer both of them? Both of them.
So, there we go. Right.
Yeah. So let's start with Medicare. So if you're a non-participating provider and you bill to Medicare, you can balance bill the patient. There's not a limiting charge on DME like there are physician services. So you can balance bill the patient above what Medicare's allowable amounts are. So for example, if you decide that your office wants $2,400 for every case that walks through the door as a non-participating Medicare provider, as long as you do not accept assignment of benefits, you can collect $2,400 from that patient. You can allow the checks to go to the patient, that therefore they're getting reimbursed. and the $2,400 is yours to keep if that's what you want per case, even though the allowable in that region and the paid amount may only be $900. You can keep that $2,400. In most instances, the Medicare patients have a supplemental policy that will pay 20%. Medicare covers 80%, and the supplemental will cover 20%. But in some instances, if you do not accept, and they have like TRICARE for Life or a supplemental plan F, it'll pay up to your full billable fee, to whatever that billed amount is, and the patient's not out of pocket at all, anything. So that's another reason why I think you need to stay out of network, is because you have some opportunities to get your full billable fee in some
For
instances.
Medicare. And that's true in all states. I think we can say that too.
Yes, it is.
So that's it for Medicare, absolutely. And I can attest to that, we get the full billable amount sometimes. And as long as you're non-participating, you can. If you're participating, you're accepting the allowable amount.
Correct. And you have to accept that allowable amount.
Right.
Now, with group health or commercial insurance policies, balance billing is allowed in most instances.
As a out-of-network biller.
Correct.
Right.
If you're at an out-of-network provider, it is allowed in most instances, unless it's plan specific. There's not an insurance company like Humana that doesn't allow balance billing. If you're non-participating or you don't have an agreement in place, you can balance bill that patient. It's allowed.
Right.
I always recommend that wait until you get that explanation of benefits and see what that patient responsibility is, and that'll be your clue whether you can balance bill or not, or if the claim paid wrong. So make sure that you review what that patient responsibility is identified as.
But if you have that's back to, so if you don't have a contract, you're doing out-of-network billing, then in pretty much most states, we call that courtesy billing, especially if the checks go to the patient.
Right.
Now, if you accept the checks, then that by accepting the check with some policies, well, most policies, it means that you're accepting the allowable amount.
Correct. Even if you're non-participating and you accept assignment, then you are taking the risk of losing that flexibility, and you have to honor those.
But if I just courtesy bill this, I'm out of network billing, I don't have a contract with them, I fill out the form and the check goes to the patient, then I can bill them my normal billable amount. So
correct.
You have to be careful whether you accept assignment of benefits or not.
Yes.
And that's true in each state as well. So I think we got that one. That was
Absolutely.
a great question. There's a lot of good questions, by the way. So I think we answered those. If not, type something else in. We'll move on down. The next one said, should a provider, a dentist, have two NPIs, one for dental office and one for sleep office? I understand that you have one for the business, but what about just the provider?
The provider should not have, they don't have to have another type 1 to identify themselves, sleep versus dentistry. They want to keep their one. Now, if they have a type 2 for their dental practice and they want to start a sleep practice, they'll need an NPI number. That doesn't mean a new tax ID number and all of that, setting up a new corporation, but you can obtain a type 2 for a dental sleep practice name if you want to identify yourself as that for marketing purposes.
You can do a DBA or something like that?
Yes, you do a DBA on your tax ID under that in type 2 NPI for the dental practice. So, or I'm sorry, dental sleep medicine practice. Right. So they can do that.
And we could talk, if you want, after this, so if you type back in and you want more information, there is a strong argument to be made to start a separate corporation if you really want to make this a big part of your practice. I did that, and I was glad I did, and I can tell you why I think that's maybe a good idea in some situations, but it's not necessary for this additional NPI number. Fantastic. These are great questions. All right, a good friend John here asked a question. If a provider is presently a DME provider with a type 1 NPI, is there a fee involved to move from a type 1 NPI to a group type 2 NPI or another Medicare application process fee? I'm not sure I understand that. Hopefully you do.
There is no fee associated with obtaining a type 2 NPI number. The NPPES registry does not charge you to do that. So you'll get that for free. There's no fee associated.
That's, I heard that earlier. The insurance companies pay for that, but we don't.
Correct. For
Okay, yeah,
CAQH,
I
all of
learned
that.
something. See,
Yes.
right? Okay,
Yeah.
okay,
So there's no fee associated with getting your NPI number.
okay.
And so that's free. If you fill out a Medicare application under your type 2 and you already have one under your type 1, that's not a problem. I don't know why you would necessarily want to do that unless you just wanted to do it under your corporation, which is completely fine. But right now they're waiving that processing fee. So there's no fee associated with Medicare to do that right now. So if that's something you wanted to do, now would be the time to do that.
Yeah, right. I think the take-home message. By the way, you will get your CE. Feel free to log off. It's getting close to 9, but we encourage you to stay on. There's 2 or 3 other great questions. Any other questions you want to put in, we'll stay on for you. But the take-home message before anybody gets off here: if you want to do this, now is the time to do it with your Medicare application. Saw
Absolutely.
someone typed in the chat, "Can I get my money back too?" I mean, it's a hassle to go with those fingerprints. It's not undoable, but you got to go down to the county and you got to, and I know
Mhm.
one of our members they smudged and they didn't like them. They had to go back and do it again.
Yeah,
So right now is the time to do your Medicare application if you're going to do it.
absolutely.
And I see
Yeah,
no reason. This is going to be a double negative, but Lisa and I are from Kentucky, so I can get
it's
away with
allowed.
it. There's no reason not to apply and be a non-participating Medicare provider because you're just leaving money on the table. There's free money out there from the government that these
Yes.
people have worked hard to obtain, and why not get that money? And you
Mhm.
can balance bill them if you want more than that money. But they're just why not do it? It's not that hard. There's really no
Right.
reason
Well,
to
and
not do it.
in the jurisdiction A, which is in the northern part of the United States, Massachusetts, New York, that area, the Medicare allowable is not almost
Almost two
$2,000.
grand, yeah.
It's
And
almost 2 grand.
that's just for the
So,
Medicare amount, not to mention the
right.
supplementals paying more possibly if you want. So
Absolutely.
if it
Yeah,
weren't too daggone cold, I'd move up there. But so I guess you pay a price for being in
exactly.
Florida because it's the lowest paid region. So
Yes, it
come
is.
here if you want sunshine and poor Medicare reimbursement. But that's another subject. So next
Yeah.
question on here. I reference to opting out of Medicare. Is there an option to opt out of Medicare Advantage plans?
There are some states that require you to be a Medicare approved provider. Michigan is one of them for Blue Cross Blue Shield. For you to be able to see Medicare Advantage patients, you have to be a Medicare provider. Most of the time, in all the other states, I don't know of any other one other than Michigan that requires that. I'm not saying there aren't any, it's just I'm not familiar with any other except Michigan, that if you get credentialed with commercial insurance, you're already you're credentialed with those advantage plans as well. You don't have to take those particular plans if you don't want to. I guess I'd like to probably have a conversation to find out the thought process as to why, and maybe that's a sidebar conversation. I'd be glad to have a conversation with to see if we can't work it out and figure out what we need to do.
Yeah, email us there at info or just type in consult. Even Lisa herself will answer the question for
Yeah,
you if
absolutely.
need to, because I think she needs a little bit more information.
Mhm.
Friend of ours, Rob here, asked this question. Very common, very good question. We could probably spend an hour. I think we did an out of network billing seminar a while back, and
Yeah.
so this is a loaded question, but I think we can give them an answer to it.
Okay.
If insurance says they're going to pay 70%, so we do the instant eligibility check, we're
Hmm.
out of network, they're going to pay 70% after the deductible. We know the deductible is only $500 left to be met. How in
Hmm.
the world do we know how much we're going to get paid by them if we're out of network?
Well, you put on a blindfold and throw darts. That's what I figured out. That's the only thing I know for sure. Well, it is an unknown. So what we do is for all of our four-pillar billing clients, we provide them with a maximum out-of-pocket calculator. That way they can narrow it down as much as possible. What I usually tell the providers is you can expect a minimum allowable on average what Medicare is in your region. That would probably be the minimum. Most insurance companies, you'll never hear me talk in absolutes, but most don't pay below Medicare. They may pay more, but they don't pay below. So
Right.
we give you what we have seen as the estimated average at a high level, and then the Medicare, and it gives you a range of somewhere of about $1,000, maybe a little bit more variance between those two
Hmm.
things. But as you get claims paid, if you keep a spreadsheet with all of that information about what that allowable is, you'll start to be able to fine tune that dollar amount and get that range even sharper. The best thing that you can do is provide a financial agreement to your patient, which if you're a DS3 member, they're embedded in the software, and you can give that to them and say, this is what we're expecting. But all of our maximum out-of-pocket calculators, you can print them, but they come with a disclaimer. It says this is strictly an estimate. But you can fill out that financial agreement and say, patient A, you won't owe more than, here's your maximum that you will ever owe us. And it could be your cash fee. That way, if they pay less than that, then you have a safety net built in. Sometimes you may take it on the chin a little bit, maybe. So it's very hard to gauge that, but we try to give you the tools that you need to make a really good, educated guess about what we're seeing in the market.
I think that's a great answer. And a couple things I'll add to that. A few years ago, 4 or 5 years ago, we didn't have enough data. There were so few people doing this that we couldn't hone that in. So we're getting better at honing that in for the people we do billing for, because we have data to go by. And then also you have to decide if that's one of the reasons you may want to go in network. If you want to go in, if you want to know what they're going to pay every time, then you go in network. But then you're a little bit handcuffed to all the regulations. Like I finally have decided to go in network with Blue Cross Blue Shield because all the patients who had that had HMO. And they had no out-of-network benefits, so they would get no coverage. But there's some things about that I don't like. Everyone has to try CPAP first, no matter how bad their apnea is. That's what their regulation is. So I'm stuck with that. Someone has an HI of 15, they have to try CPAP first before I can get payment. So HMO in-network's not always perfect, but I know how much the allowable is for those. On the out-of-network, the other thing we can help you with is learning to get averages and be comfortable taking risk. And saying, okay, I get more on some, less on others, but I get to a point where I'm happy with it. So there is a little bit of guesswork there, but it can be navigated along with help, and that's we kind of do a combination of both in my office. I think I'll answer this one unless you have a better answer for this. But do you have a good recommendation for a collection agency? And my answer to that is no. And I'm Lisa May. But what I have started doing, if you have a good financial agreement, and you're clear on your policies, and you're not doing anything monkey business while you're doing everything above board, which we do, and someone doesn't pay me, then I have started hiring my attorney to go get them. I have an attorney who's willing to to write them a letter for a fee and willing to take them to court for a percentage of what he collects. And we have a lot better results of getting that money from them because I have all the stuff in place. I've used collection agencies in the past, and my experience with them is they just call and harass people. I don't know that they take 50 cents on the dollar, and I'd rather give that money to an attorney, assuming it's not $20 or something. And it's rare that we have to do that anymore, but that's my route. Lisa, do you have any other offices that use a collection agency, or do you have any recommendations?
We don't have any that use collection agencies, but the other thing that that you can keep in mind, if the insurance check goes to the patient, you can bill them and they keep it. Let's just say that they decide not to bring you the money for some reason. The check went to them and they're keeping that money. So you can send them and you can bill them your full billable fee until they bring that to you. If they don't bring it to you, it is illegal, and I'll use illegal, I don't use it very often, but illegal for the patient to profit from any medical services. So what you can do is you can send them a letter too saying, since you haven't brought us the payment in for this, we're going to be contacting the insurance company to let them know that we did not get payment for services. Then in some instances, the insurance company will contact them and try to get that money back because it's illegal for them to profit from it.
Maybe we're a little bit better because we have pretty clear expectations, and but it certainly has happened to me. Believe it or not, the one that sticks out in my mind was a retired dentist that got the insurance money, didn't want to give it to me. That was kind of, that
story never gets old. I tell people that all the time.
And it's a true story. I guess I've got my money's worth out of the story. But all right, I got a couple more here. Well, one more. I got one. Someone just typed in Arizona. I'm not sure what to do with that. But if you have a question that goes along with that, we'll be happy to answer it in a moment. But this one here, can we still submit a claim to a secondary insurance company if we accept assignment for the straight Medicare case?
So you accept assignment of benefits and Medicare is primary.
Right.
Most of the time, Medicare will forward that automatically to the supplemental policy if they know about that, to where you don't even have to file a claim. They will just automatically forward that. If they do that, then when your primary explanation of benefits comes in from Medicare, it will tell you that it was auto forwarded or auto crossed over. Sometimes it'll say auto crossed over, and it'll tell you what insurance company it was submitted to. And that supplemental policy will go ahead and pay based on that being crossed over from Medicare, so it doesn't require anything to be done. And whatever the primary does, if it's marked, as I accept assignment, the secondary will automatically follow suit and assume that it's supposed to be accept assignment on their claim as well. So they won't do anything any different than the primary.
All right, man, I got through all the questions. If anybody has any more, type them in. We'll get to them right now, or we're going to be heading out again. So if you want to come to the course, don't forget to type course to get your discount this week. If you type it, someone will contact you and make sure you get registered for that. Of course, you can sign up later. It's still a great deal, even at $500. And you get a full 4 hours with Lisa in addition to 6 hours with me. And even if you're already doing a lot of this, we're going to teach you the systems how to do this going forward. If you want to know more about what we do, then just type in consult. And don't forget, we have another webinar coming up in a month. We're here for you at Dental Sleep Solutions, regardless of the dental sleep question or concern or challenge. We're here to help you with it. And we're getting ready to get off, but we got a few other questions here, at least one more. Do you have legalese for federal versus state that use for the statute regarding profiting from care? Do you have, so I guess so.
It's usually written in the summary plan descriptions. I can look and see if I can contact a friend that works at Humana to see where it is in their agreement that the patient, cannot profit from that. I'll see if there isn't something that I can find from them to get the exact regulation, and I can send that to them.
Well, great.
Yeah.
So again, if you want more detail on the stuff that we went over, you can get a hold of us at info@dentalsleepsolutions.com. You can just type in, billing consult. If you want to know something billing particular, we'll make sure you get hooked up with the right, because we have a member support team that all they do is help the dentist with all the other challenges of dental sleep. And then we have a whole billing team that they just specialize in the billing. But if you just contact any of us, we'll point you in the right direction to the right team member to help you answer this. Well, Lisa, I learned something. I knew I would. I saw your slides, and I started to call you up and say, what does all this mean? I thought, you know what, it'll be better if I don't ask, because I can learn as well. Because that's not the stuff. I'm like most dentists. I just want to get in there and treat patients. I don't love the paperwork. If you want our help with doing a Medicare application or insurance, that's what Lisa does and her team all day long. Contact us as well, and we can help you with your billing itself or get that Medicare application. Thanks for putting this together. It was great.
Yeah, you're welcome. Thank you for inviting me to do so. I enjoyed it.
I think you're in charge.
I am.
So you get to hit the button to close us out when we're ready to go, which I think is about right now.
All right. Thanks. Have a good evening.
All right, you too.